Good morning. Good morning, everyone, and welcome to keynote session 2 on an extremely topical subject, and that's the whole issue of probably one of the most precious capitals that we have, and that's human capital. My name is John Wong. I am the Chief Executive of the National University Health System in Singapore and Senior Vice President for Health Affairs at the National University of Singapore. Again, I'd like to thank Detlef, Julian, Hogg, and the whole team at the World Health Summit for inviting myself and my colleagues on the panel to discuss this important topic. So perhaps I can just frame in a few slides what we hope to do. Well, the good news is that global life expectancy has never been so long as it's had in the last 50 years. Life expectancy for both men and women have increased substantially. But with this increased lifespan, we've also seen a significant increase in the global burdens of chronic non-communicable diseases. You can see cancer, ischemic heart disease, diabetes, all increasing by double digits. Stroke has also gone up. And what we are faced with is now a global shortfall of healthcare workers. It's projected that in the next 10 years, we'll be short of 18 million healthcare workers, especially in parts of the world, including where I come from. There is a certain maldistribution, as you can see, boxed in red. Africa and South Asia are two parts of the world which are significantly short of both physicians, nurses, midwives, and other healthcare professionals. And perhaps it was a tragedy that we all saw the outbreak of Ebola in Liberia, Guinea, and Sierra Leone. All countries are very short of healthcare workers. So what do we need to do? I think the World Bank and several other organizations have put out this call that we really need to come together and try and close this massive human capital gap. There's some excellent papers that I recommend you to take a look at. The 2016 WHO paper on the global strategy on human resources for health, the World Bank paper in 2018 on the Human Capital Project, and this year, the political declaration at the UN, where they really looked at, they called on this issue and especially commented on the need of empowering women and that by empowering women, giving them better opportunities and working environment and eliminating issues of biases and addressing inequalities as a key solution. At this World Health Summit, I'm delighted that the number of female speakers that we have is close to half. And actually, we would have had true gender balance at today's keynote session, but unfortunately, some of our female colleagues could not make this morning's session. So we've got 4 speakers, real luminaries in their own right. Dr. Jim Campbell, a director of the Health Workforce Department at the WHO. Dr. Tom Katina, chairman of Aurora Humanitarian Initiative and medical director of the Mother of Mercy Hospital in the Nuba Mountains of Sudan. Dr. Mark Britnell, global chairman and senior partner for healthcare, government, and infrastructure at KPMG International. And Dr. Julie Lynn Hall, chief of staff of the International Federation of Red Cross and Red Crescent Society, IFRC, and director of the Office of the Secretary General and Special Advisor for Health. Now, what we plan to do is that each speaker will have about 10 minutes of formal comments, and then we'll have a short Q&A about 5 minutes after each speaker. That will take us for the first hour. And then for the last half hour, we'd really like to try and have a dialogue with all of you, because I think that this is an issue that can only be tackled by a true whole of society, whole of world effort. And if none of you have read this, I would like to, one of our speakers, Mark Britnell, has just released this book on solving the global workforce crisis in healthcare. And I think this is now in the second edition after just being released 4 months ago. So thank you very much, and maybe I'll ask Jim to start off by framing the issues from WHO. Thanks.
Thank you. Good morning. So I am wearing a lapel badge here, Women in Global Health. And for those who were here yesterday, we had an excellent session talking indeed about the issue of women's economic empowerment, the gender equality issue. Women in the workforce, 70% of the global health workforce. And all of this discussion around the 18 million shortage, the human capital discussion, has to come back to ensuring that we've also got gender transformative policies happening. Congratulations to the World Health Summit for ensuring that even in the representation across all of these sessions, there is gender representation at equal levels. I wanted to speak to you about three key things. Firstly, the political consensus that has come out of some of the deliberations between member states on universal health coverage. Secondly, what is the emerging opportunity that comes from that? And then thirdly, what are some of the work that the World Health Organization, with member states and with all relevant stakeholders, are taking forward to deliver on this? So firstly, the political consensus. Indeed, as John just showed you on his slide there, we have the political declaration coming out of the high-level meeting on universal health coverage. And we also have the Global Action Plan on Healthy Lives and Well-being, which puts it to an emphasis of how do we actually translate that consensus into action at the country level. John put up some of the data there because the political declaration notes with concern about this global shortage of 18 million health workers if we are to get close to achieving our primary health care ambitions and our universal health coverage ambitions. And we should note that this is a global challenge. This is not a debate that is only limited to low and middle income countries. Let's give you an example here from our host country, Germany. Minister Spahn was here speaking yesterday evening in the opening ceremony. And he said the comment, not verbatim, but along the lines of, good global health begins at home. And here in Germany, there is a substantive challenge around the workforce of the future. And we saw in June this year, the Minister of Health, along with the Minister of Labour and Employment, and I would question how many people are here in the audience or here at the summit who represent the employment and labour sector, and the Ministry of Family, the three ministries coming together to put forward a concerted action care plan. And what does that plan try to achieve? It tries to get ahead of the projected shortage for universal health coverage, and particularly in the nursing occupation, which globally is 50% of our workforce. It invests more in education. It takes away fees for education, which is obviously a barrier to many people joining the profession. It ensures there's an allowance to be in education. It ensures that the wages and the attractiveness of the profession is increased. Wages will go up. And it also links some of the discussions around increasing the flow and, critically, decent work. Making sure there's a connection between women in the workforce, 95% of the nursing occupation women, and the social protection mechanisms that are there. Care for the family, et cetera, et cetera. So we're seeing the likes of Germany and other high-income countries, OECD countries, trying to address this challenge. In low and middle-income countries, what is the scale of this? We've seen the evidence published in the Lancet Global Health around the price tag to achieve SDG 3. And this price tag goes into the billions and trillions of dollars. And when you look and you break that down in terms of indicatively about $60 per capita per annum, over 40% of that goes into the workforce. That's an average across 67 low and middle income countries. And as you build the workforce, that increases year by year by year because you have a recurrent cost. You have wages to pay as well as education. Now that study does not include the cost of education. If you add the education cost, which is different than Ministry of Education sector often, then you're looking at an indicative investment of 60 to 70% goes on the people, the education, the skills, and the jobs if we want to achieve universal health coverage. And that's then very, very similar to high-income countries' OECD. 60, 70, 75% is the investment in people. So it's a major challenge. It's the challenge about how do we get the money, the investment, the fiscal space, the policy to invest in the workforce. And how do we get the money to invest in job opportunities, economic opportunities, in particular for women and youth. They're the health workforce of the future. This is the second point, the emerging opportunity that we can see before us. As well as the political consensus around UHC, we now have an economic consensus. John talked about the Human Capital Project from the World Bank. They have recognized that the best investment is education, health, and skills if we are to achieve the Sustainable Development Goals in their entirety. Universal education, universal health, decent work, skills, and employment. So it cuts across all the SDGs. And the World Bank is now ready to start to invest significantly in low and middle income countries with the opportunity of some $18 billion that they're sat on ready to invest. So we need to put the skills agenda at the top of this. We will not achieve universal education or universal health without the skills agenda and the people to deliver those things. So that's an opportunity. The second opportunity is the International Monetary Fund. In June this year, they launched a new strategy on social spending. And you've seen a major shift in thinking as a result of this. They recognize that in the current post-financial crisis, with lots of governments driven into austerity measures, they recognize that you have to invest in education, health, and social protection. And that is a completely different argument than the last 30 years of reducing public sector spending on health, education, and social services. They're actually saying we need to invest and we need to reconsider. And we've learned the painful lessons of the financial crisis in high-income countries. In Portugal, in Ireland, in Greece, in Spain, where they've had to cut wages, cut jobs, and that's negatively impact healthcare and social protection services. So the IMF has changed. What's the third opportunity here? Minister Spahn also mentioned yesterday that Germany in 2020 will be the presidency of the new commission coming forward, this rotating presidency. But there is a new commission about to be appointed in November that will take forward. And one of the things they're looking at, what will be their future development policy? And part of that, part of the discussion is how to invest in human capital and women's economic empowerment. So you have World Bank, IMF, other international financing institutions, the European Commission, all suddenly engaged in how to action the evidence. And the evidence about investing in health workforce gives you healthcare, broader economic dividends, and it pushes all the work on gender equality as well if we get it right. So that's the second point, this economic opportunity, which is for those people who've been in this space for many, many years, recognize that that often hasn't been there at the same time as our health for all discussions. So what is the World Health Organization doing about this? We noted with appreciation the outcome statement of the G20 in Okayama just this month, And the G20 from Japan put forward their support to what the WHO, ILO, OECD, and now the World Bank are doing on a program to invest in the health workforce and leverage the contributions of the international financing institutions. And our colleagues from ILO, I believe, are here today in the room. The other thing that we're doing, we're actually trying to say, how do we crowd in the available finance and the available resources that exist? The European Investment Bank spends $6 to $7 billion per year around some of its priority work in health and education. The World Bank is sat on $18 billion. We have a shortage of the health workforce, which needs investment. How do we put some of that money together? And we are working with the European Investment Bank, and we had announced this in New York alongside the political declaration. How do we establish an instrument that is available to those countries that have a shortage, that want to invest in the workforce and want to accelerate education, skills, and jobs? We hope in the new year that we'll be crowding in an investment vehicle which will enable over $1 billion of new capital to be targeted at country level to address the 18 million shortfall of health workers. That has to be, though, a discussion about employment. It has to bring our partners from labor to the table. It's a health issue, but it's also a jobs issue. It has to bring social protection to the table. Most jobs are going to be taken by women and youth, and we had to put mechanisms to ensure that those careers are attractive, they're supported, that the occupational health and safety, the harassment and violence from work are not part of the norm. We also have to address some of the issues around the gender pay gap, where women are being unfortunately disadvantaged when it comes to pay and remuneration in many countries just because of gender dynamics. So that's the opportunity. That's what we're taking forward. We believe, the political consensus gives us an opportunity. The fiscal, economic consensus that is emerging has to be grasped, but we have to make sure that this is an intersectoral agenda. And I would challenge all those people, start thinking, who are your labor and employment colleagues that you need to be having discussions with? Who are your gender and family and social welfare colleagues that you need to be having discussions with? That will give us the investment that can carry this further forward. Thank you very much.
Thank you very much, Jim. So I'll tell you what, we'll do the Q&A as a panel discussion. That'll probably be more lively. So maybe I'll call upon Tom to share the perspectives from probably one of the key areas where there is a significant shortage of healthcare workers. Tom, please.
Good morning. This is really quite an honor for me to be here, so I want to thank John and the rest of the group for the invitation. I think being part of this really distinguished panel is quite an honor for me. I can't offer the same policy experience and background they have, but if you'll allow me, I want to give you, let's call it a worm's eye view of the problem of this very important issue of human capital and capacity building. I live and work in Sudan's Nuba Mountains, which is kind of right in the middle of this area here. It's a region about the size of Austria, and I've been there for the past 12 years. I'm a medical doctor and surgeon, and I've been there for all this time. We have been in a state of civil war against the Khartoum government for the better part of the past 63 years, and for the most part have been cut off from international donor aid. Just to paint a picture of the region, there were 2 visitors that came to our hospital. They just left last week. And for them to travel the first 120 kilometers of this journey took them more than 24 hours to get out. And that got them to a refugee camp in the northern part of South Sudan, where they just made a cargo flight to get out to Juba, and from that point, they got out to the rest of the world. So we're pretty remote. Any drugs or supplies that reach us, we have to buy in Kenya. It's got to go by road through Kenya, through Uganda, all the way through South Sudan to reach this same refugee camp in Ida, which is northern part of South Sudan. As it passes through South Sudan, it's got to pass through multiple checkpoints manned by soldiers that haven't been paid in the past year. So as you can imagine, it takes several weeks to reach there and is very expensive. From that point, we have to leave our hospital, go down to this refugee camp, pick up the supplies, and bring them back. Nuba is home to 1 to 1.5 million people. There are no paved roads. There's no electrical grid. There's no phone service. There's no running water. And in this setting, we run a 435-bed referral hospital, where we're the only referral hospital in the region to treat everything from major surgery to TB and leprosy to chemotherapy for cancer patients. Our hospital in 6 clinics treat over 130,000 patients a year, do 2,000 major and minor operations, and admit 7,000 patients to our wards. We first opened the hospital back in March 2008, so we're fairly new. My goal at the time was to stay until I could pass this work on to the Nuba people. We're slowly getting to that point. Now at this time, if you can just get a picture of the area, there were a few functioning primary schools in this entire region, again, the size of Austria. There was one high school that had just opened, and not a single high school graduate for the entire region. We started our work with 8 expatriate staff. They were from Kenya and Uganda. And we have 15 local Nuba staff, all of whom had no prior medical experience. In fact, of the 15 Nuba, the person with the highest education level had finished primary school. I was the only doctor there, and remained so for the next 8-10 years. We quickly realized that only through education and capacity building for the staff would we ever be able to pass on a lasting legacy to the Nuba. Now, we also realized that we need education and capacity not only for the staff, but for the population at large. It's very obvious that good health outcomes are much more difficult to achieve in a population with very low education levels. In fact, in Nuba today, 70% of people have never been to school of the population. Just as an example of what we're up against, I want to use the example of my own family, my wife, Nazima, who's here, and my sister-in-law, Kechi, who's not there. My sister-in-law, Kechi, is probably in her early 30s. She's the same age as my wife. And Kechi's the second wife in a polygamous marriage, and she's got 2 small kids. Now, she and my wife grew up together. They attended primary school together in Nuba Mountains. And, you know, the school was your basic rural school. It was under a tree. The teacher had a piece of charcoal that he used to write the letters on a piece of flat stone. That was their primary education. After those few years of school, Kechi dropped out, but my wife was able to continue on to finish primary and secondary school at a school set up in a different part of Sudan by the bishop. We ended up sending out to nursing school. So we went to visit Kechi last month, and for some reason, we got on the topic of tuberculosis and wasting disease in general. And we said, Kechi, what do you think causes TB? And what causes these wasting problems? And she's very confidently, she said, well, that's because the person is inhabited by a wizard. A wizard's a malevolent spirit that inhabits the person's body and then eats the person from the inside. That's why they lose weight. And we talked about germ theory. We talked about other possible causes. And she said, no, you people are crazy. It's caused by the wizard. We said, okay, if that's the case, how do you treat it? And she said, the only treatment is you have to go to the Kujur. And Kujur is the colloquial Arabic for the shaman, who's the local kind of the faith healer. Each village has one. You have to go to the Kujur, and the Kujur can then kind of reverse the spell and restore the person to health. We said, well, what if they come to the hospital? Can't they be treated there? She said, no, your drugs are useless with this problem. And this is my wife's sister. They grew up in the same house. So I think you can see how these issues will lead to delayed presentation at the hospital. There are many other cases like this. The common thought for diarrhea is that there's a wound in the baby's anus, that you have to wash the baby's anus out. So all these grandmothers are there. These poor babies have diarrhea, and on top of that, the grandmother's washing the baby's anus out. So the kids come in profoundly dehydrated. So we have a huge challenge with education, not only for our staff, but for the general public. So what to do about it? To help address the general dearth of health knowledge for the population, our outreach clinic staff, we have these 6 clinics, they go out and they teach the community health workers on topics ranging from everything from proper hand washing to malaria prevention to danger signs in their children when they bring the kids to the clinic. It's these really community health workers who are entrusted with the task of education for the communities, and they really do a fantastic job. Now, for our staff, the other issue that Jim was talking about, as I mentioned, we started with 15 staff, 15 local people, none of whom really had any medical training to speak of. So we started out just doing basic general medical education courses with them. We had CME classes combined with intensive bedside training and practical learning. And that went on for the first few years, and it really paid off in June 2011 when our region erupted again in civil war, and all of our expatriates left, and left us with just the local staff. Now, the expatriates included our one and only anesthetist, our one and only laboratory tech, our pharmacy technician, and all the in-charges of the wards. So really, all of our expertise left and left us without any of that. And really, it was in our on-the-job trained staff really picked up the slack and did an incredible job. We were able to continue on with the work without any drop-off. Just to give you an idea, the expats were evacuated about 6 o'clock in the morning. It was June 16, 2011, I won't forget this day. And 2 hours later, at 8 a.m., we received 2 or 3 truckloads of wounded people. They were civilians that had been attacked by the Sudan Air Force. So there was a young lady, had her arm half blown off, her cousin with her hand blown off. So we had to take all these people, take them to the operating room and do general anesthetic and then operate on them after the loss of all these professional staff. And I remember that as the only referral surgical hospital, it was imperative that we keep functioning. There was absolutely nowhere to refer these patients to. We were pretty much it. We were totally cut off. So the staff really stepped up and did a great job. However, despite the performance of the on-the-job trained staff, we also realized that we needed to provide the staff with more of a general foundation of knowledge. Around the same time, in 2009, there was a consortium of religious sisters set up a nurse training school in South Sudan. So we started sending our staff out to that school for training. And up till now, we sent 20, and they've gone and come back. We have 10 more that are in training now in nursing school. I think around 60-70% are female. We've sent 8 staff to school for clinical officers, which, if you don't know what a clinical officer is, they're kind of between a nurse and a doctor. They can do outpatient clinic and this kind of thing. We've had 4 that have gone to lab school, 2 to pharmacy school, and 5 to medical school. So our first Nuba medical doctor will join us in May of 2020. This will be the first Nuba who was born and raised in the Nuba Mountains, was sent out for school, and will come back. So I can't wait for this guy to come back and we start passing on this stuff to him. I'll give you, I think it's gone off. There was one more slide I wanted to show you. Oh, there it was. There it is. Just to give an idea about our, if you have any anesthesia nerds here, this is our anesthesia setup. That's it. That's called an OMV. Anybody familiar with the OMV? Oxford Miniature Ventilator. It's a drawer anesthetic. It's a fantastic device. This thing costs about $2,500. It's sold by Diamedica, which is a company in the UK. And we can do everything with this. Our best anesthetist finished 8th grade. He's a primary school graduate, and he was trained on the job and operates this thing flawlessly. And we operate on everything from premature babies, 1.5 kilos, to old people. So it's amazing what you can do with a combination of on-the-job trained and a few skilled people. As I was saying, most of our folks are still on-the-job trained. And for the region, we have a massive deficit of healthcare workers for our 1.5 million person catchment area. In the Nuba Mountains, there are a total of 200 health clinics. Now, when I say health clinics, most of them are very primitive structures. It's straw with a few poles set up. And none of them are staffed by health professionals. So what we want to do now is we want to open a school in January 2020 to train a total of 90 healthcare workers. This will be 30 registered nurses, 30 midwives, and 30 clinical officers. It's still kind of a drop in the ocean, but I think it's somewhere towards achieving our goal of staffing all these clinics really with health professionals. Now, mind you, to do all this, to run the hospital, to run the clinics, to start and run this health training school, we are fully dependent on individual donations. Except for a donation of vaccines and TB leprosy drugs, not a single dollar comes from the international donor community. We're pretty much on our own. And from the Nuba Mountains, just to kind of finish up, from our region, we've had about 200,000 to 300,000 people have left Nuba to go to refugee camps in South Sudan. And probably the main reason they've left, besides the fear of getting cut to pieces by a bomb, is the lack of educational opportunities in the mountains and the poor access to health care. I would dare say that the lack of educational, of course, job opportunities are the two main driving forces behind movement of people to refugee camps, mass migration, and the brain drain that accompanies, that cripples local development. So certainly a proper investment in these areas would be money well spent. So thank you for listening.
Wow, thanks, Tom. You must be Duke University's most illustrious alumnus. Well, I think that going from now, from remote Sudan, I'd like to call on Mark now to share his interactions around the world with governments on how we can address this global issue. Mark Britnell, please.
Well, I'm sure that I speak for all of us when I say that's a humbling speech that we've just heard. The World Health Summit, in my opinion, is a very broad church, and it brings together actors from the government sector, from the non-government organisation sector, charities, and the private sector as well. I've got 10 minutes to persuade you that the global workforce crisis is an opportunity for all nations to raise their productivity, raise their prosperity, and create and generate health for wealth and wealth for health. As you can see, in terms of my own position as Global Chairman of Healthcare for KPMG and former Director General of the English National Health Service, I get the opportunity, along with my firm, KPMG, a global firm 150 years old, that works in 157 countries, to actually look at health systems as they operate on the ground. We don't deal in theory, we deal in practice. And we work for governments, the private sector and the public sector. As you can see here, last year, over 4 years, I was one of the 12 members of the World Economic Forum. And as you know, we get the opportunity to speak truth to power once a year in Davos. We have a wonderful global observatory at looking at the developments to try and make sure that our human resource in healthcare meets the challenge which is so eloquently being presented by Jim just a few moments ago. But one thing I've noticed, and the driving force behind this book, which John kindly plugged, and by the way, there are 20 free copies at the front, so if you catch me, you can have a free copy later on. I should also say that all of my royalties go to prostate research. I survived prostate cancer at the age of 41, 11 years ago. So I'm not plugging this book so I or KPMG can get richer. This is my contribution after spending 30 years in healthcare, leading hospitals, regions, countries globally, public, private payer, and provider, to show you that actually there is hope. But one reason why I decided to write this book is I was getting tired of reading lengthy, introverted, loquacious articles that celebrated the problem more than they cared to solve the solution. And my message to you today is that if we actually work together, we collaborate cogently, with pace and purpose, we can solve the 18 million shortfall in healthcare workers by 2030. I pay tribute to the World Health Summit and also to the World Health Organizations. In writing my book, we looked at 7,000, no less than 7,000 articles on human resources in healthcare. You'll be pleased to know that I didn't read all 7,000, but Dr. Refsum and my global team looked at many thousands of articles, and with the exception possibly of some of the great work from the WHO and the Lancet, most articles concentrated on the size of the problem and didn't actually practically spell out what solutions exist. And I'm here to say today that actually it is impossible for any one agency, no matter how lofty or how noble, to solve this pressing issue, which I consider in my 30 years of healthcare work to be the biggest single issue confronting healthcare today. Not health, as we've already heard, but healthcare today. Now, Jim concentrated in large part, and our previous speaker just concentrated exclusively, quite rightly, on the pressures in low and middle income countries. But also, as Jim referenced, this problem is now spreading to the developed world. Is it a coincidence that all of a sudden we're talking a lot more about the global workforce crisis as soon as the West catches a cold? I'll let you ponder on that question. But even so, and as a person that gets to travel 3 weeks out of 4, last week I was in the United States, the weeks before that in India and Brazil, you can see from this slide that we are honestly hurtling towards a future where there is simply too much work and not enough workers. The richest country on the planet that spends 18% of its GDP on healthcare, by 2025 will be short of 1 million nurses and between 105 and 125,000 doctors. Think about the impact that has on the Philippines, on Eastern Europe, on India, on South America, and the Caribbean. It is not a zero-sum game. In India, where we're helping Modi build universal healthcare in 7 or 8 states in India, you can see that he is actually raising his spirit and level of ambition in spite of being 4 million doctors, nurses, and health workers short. And Japan, where I spend quite a lot of my time and have a profound respect for Japan, because I often say if you want to see the future, go visit Japan, because of its aging profile, its sluggish economic growth, and the fact that it has an ambivalent attitude towards international migration. Japan has seen this problem coming for over 20 years. And when I launched my book in Japan in July this year with the Chief Medical Officer Suzuki in Japan, they have trebled the number of nurses and still are 250,000 nurses short by 2025. In the infamous words of the Beatles, money can't buy you love. Money can't buy you workers. But the first thing that we should recognize, and I'm sure I speak for most people in this audience, is that, and this is the first chapter of my book entitled Cognitive Dissonance. And for those of you that aren't psychologists or psychiatrists, cognitive dissonance is the ability to hold 2 contradictory and competing values and thoughts in your head simultaneously. In short, it's called being a politician. Because we know this solution, this pressing need, will take at least a decade to solve. But how many times have we heard politicians talk about their love for healthcare workers, but actually fail to provide sufficient staff for their health system? How many times have we heard politicians believe that the powers of the 4th Industrial Revolution will solve most of our problems without preparing the health industry in particular for enormous dislocation and disruption? My friends and colleagues, it will take 10 years to solve this problem, but I am confident from the work that I've done, the nations I have worked in, and the work that we have researched, that if the public and the private sector can get together and start to think about medium to long-term investment plans over 5 to 7 to 10 years, I believe there is a way that we can make sure that our health needs over the next decade and beyond can be supported by a well-skilled, well-trained workforce that unleashes the power of women, of youth, and dare I say it as well, people who are approaching or indeed have passed retirement age. All these people will be needed to meet the challenge. Now, I haven't got time today to go through the 10 solutions, but they're all in this wonderful book. Did I mention the book? But let me tell you that all of the solutions here I have seen or worked on, and they have worked at scale. So let me just, in the 5 minutes that are left to me, talk about the 10 so you get a flavour of what I'm talking about. The first thing to say is that actually the debate about health workforce is taking place entirely on the wrong territory. The history of feudalism and the history of capitalism over 400 years suggests that the defining feature that distinguishes poor and rich countries is their productive capability. If you chart feudalism, chart capitalism over 400 years, rich countries got richer because they were first to the chase on productivity. We need to re-engineer, reflect, retrofit some of the arguments used by distinguished academics and others to make sure that we nail this issue that health is wealth. And we can make human beings, healthcare workers, more productive. Because quite simply put, there is no other plan B. We have to make sure that we can become more productive. And the good news is that when you look at the ingredients of productivity, skills, education, research, infrastructure, the rule of law, good governance, good leadership, and slides that work. Could I have my slide back, please? If you think about these ingredients for healthcare and for productivity, we have them in abundance. The trick is to harness them over 5 to 10 years and not to run away from the debate about productivity, but to face politicians down to make sure they put their money where their rhetoric is. Secondly, we need governments to think of a different way of training healthcare workers. I do not believe, having travelled the globe for the last decade, that many health workers will ever be made redundant. The gap is too big. We need to find ways in which we stimulate an oversupply of health workers, because we know through centuries, through trades and unions, that actually restricting supply has been a sign of strength, but actually it's a sign of weakness and self-interest. Thirdly, we know that there are 5 models of care, ranging from a digital front door to integrated care, all the way through to blockchain, robotics, cognitive assistance, and artificial intelligence. Work that we did with the World Economic Forum, there are 5 large-scale changes which can increase productivity by between 16 and 21%. We know that patients can become partners in healthcare. We know that communities can become carers. We've learned that from the work in Africa and other places as well. We know also that professions, globally, when you look at what professionals do, at least 20% of their time is spent on tasks which are beneath them. Imagine the productive capability we could unleash if we had professionals playing at the top of their game, not being ground down. A new cadre of health workers, whether it's Irish practitioners in India, whether it's nurses from Virchow in the Netherlands, can increase productive capability and spend more time caring for patients. And we know roughly, we can debate about this, that 36% of all healthcare tasks can be supported or replaced by digital technologies. In my old university, the University Hospital Birmingham, one of the largest teaching hospitals in the UK, we are currently analysing over 20,000 job descriptions, demystifying them, and looking at the tasks that can be supported today and within 3 years by technology that exists or is in the pipeline. And we also know that as you flatten organisations, that's the way you speed up digital adoption. and therefore the organisational development consequences of changing the profile of work and the future of workforce need to be considered at the same time. And finally, before I hand over to John, there is one thing that I want you to reflect on, and if you will, I'd like you to participate in some primary research for me. Thinking about your own organisations, what percentage of your staff have meaningful objectives with meaningful performance appraisals that lead to meaningful consequences? Hopefully good, sometimes not so good. Now, who will put their hands up for 100% of the people in their organisation having wonderful appraisals? Who'll give me 100%? Don't be shy. It's not a rhetorical question. Who'll give me 80%? Who'll give me 60%? That's great. The global average is 30%. If change in healthcare is a human contact sport, we best contact human beings. We can solve this problem if we think in a different way, in a non-linear way, in a creative way, because complex adaptive problems require all the assets of society to be mobilised to solve this most pressing of issues. Thank you very much indeed.
Wow, thank you, Mark. And so now to really come up with solutions for all of us, we'll have Julie, and then we'll have the panel discussion. Julie, please.
No, thank you very much indeed. So solutions to all of this. The challenge has been put before me, and I thank you very much. I also thank the three previous speakers for really outlining very comprehensively some of the issues and problems we have, but above all, some of the opportunities we have to transform human capital. Now, I would like to really focus on an area that has been touched on by our three speakers so far, but is often an area that is ignored or hidden when we're talking about how to transform human capital, particularly in the fields of health and education. And that is those areas that at times lie outside of our formal health system. Three areas: volunteers that play such a vital role in providing health care, and obviously I'm speaking on behalf of the International Federation of Red Cross and Red Crescent Societies, and we have over 12 million volunteers around the world, the majority of whom are supporting health and social care programs. So volunteers. I would also, though, like to talk about two other areas that are often, again, hidden and not fully integrated into our health systems. Those are informal caregivers, and then the role of community health action. So to start with, volunteers. There are millions and millions of people who volunteer around the world, not just with the Red Cross and Red Crescent, but with many other organisations, to provide health care, to provide psychosocial support, to provide social care. And they play an absolutely vital role. First, in bridging the gap between home and the formal health system. And this bridging, this gluing together, this bringing together cannot be underestimated in terms of its value and in terms of its transformational capacity. These volunteers help us that bridge between home and the health facilities in terms of early detection, the capacity to do that for infectious diseases, to give those early warnings of epidemics, of outbreaks and potential pandemics. But also early detection of chronic diseases and involvement in screening programs and detecting when patients perhaps are struggling or families need some extra support. They also help as a bridge to help navigate health systems. Health and social care systems around the world are often very fragmented and very difficult to navigate without someone to help and support you through it. They help support follow-up for patients, particularly those with chronic diseases. Support for taking medication, for understanding side effects, for linking with social care and psychosocial support. And when disaster strikes, it is often the volunteers who have had some training that can make an enormous difference. When a natural disaster occurs, over 90% of people are saved by their neighbours, by someone who is a volunteer, who has some training, who is able to help and support. We know that out-of-hospital resuscitation, for example, is often done by people who are volunteers with some training. And those golden 10 minutes for a heart attack, or those golden first few days for a natural disaster, it's critical that we have people who are there, lay but trained, volunteered, willing to support, willing to lend a hand. And all of these things help to reduce the burden on our health system and hopefully help with some of the solutions that Mark was talking about. And I thank you very much for mentioning communities as carers as your 5th point, because communities can be carers. And within those communities, we know we have millions of people who are willing to volunteer their time and efforts to do that. But they're often not connected and brought into our health system as we should. And I'll come back to how we can help and support this later on. But beyond the role that they play in health, volunteers also play a role when it comes to education. It's amazing the amount of education you get through health literacy. Understanding your body, understanding health systems is a form of education and a form of literacy. And something else that we've found in the Red Cross and Red Crescent movement is that the volunteers that come and work with us and alongside others, actually their own personal literacy increases through those programs. And so what we can do in terms of adult literacy, and we know particularly for women, literacy makes an enormous difference in terms of empowerment and access to jobs. And by coming and working as a volunteer, by being engaged in the training programs, we can not just improve health literacy, but overall literacy as well. So volunteers bridge gaps between the home and health systems. They help to build literacy in many different ways, and that link with education, which we know has so many benefits and is transformative for human capital. But they also help to build trust. And I think this is something that one of our previous speakers, Tom, talked a lot about in terms of the understanding volunteers bring of communities and different belief systems. Building the trust through actually having that real understanding of where people's legitimate belief systems come from and linking them with perhaps a more medical model, building the trust and being able to bring those together. And we've seen very much in Ebola just how important this is. Red Cross, Red Crescent volunteers working in many parts of the world that were affected by Ebola a few years ago, and now obviously in DRC, helping to support through safe and dignified burials, but really because they're part of the community, understanding the cultural issues, understanding the beliefs, being able to build the trust and being able to link the community with the medical interventions that are required. So volunteers, critical. We need to embrace, to support, and link more into our health systems. Then informal caregivers, they're often even more hidden than volunteers are. They don't wear uniforms, they don't have badges, they don't have the logos that go along with all of that. But we know that informal caregivers are providing extraordinary levels of healthcare. In the United Kingdom, we know that informal caregivers, if you costed the work that they did, it would be over £132 billion per year. That's equivalent to a second National Health Service. And in many other countries, this will be far greater than that, proportionately, in terms of what they do and what they give. They build bridges, they provide that health and support. They also help to connect, but they're often very isolated and not given the support that's required. So another area where if we are looking at bridging the workforce, but also transforming human capital, this is something that we need to look into, informal caregivers. Not just in terms of what we can give them more, but what they can give us as well. A true understanding of what it really means to live with and support someone with a chronic illness, for example. A true understanding of what it means to face fear when it comes to a potentially life-altering or life-threatening disease. And a true understanding of where we get the strength from to be able to move forward with health challenges. And this can help us who are perhaps professionals within the health service actually understand a lot more. So it's very much a two-way street. And then finally, community health action. Well, what do I mean by that? I mean actually supporting communities to come up with their own priorities, the things that matter to them from a health point of view. And this is vital, it being centred at the heart of the community, and motivations come from there. We know that when communities are motivated to do things about health, enormous and extraordinary things can happen. We have some great examples from the Red Cross of tackling Zika in South America. The clean-up, cover-up and clear-up campaigns that were motivated from the communities, by the communities, did an extraordinary amount to reduce the spread of Zika, but also the spread of dengue and the spread of infectious diseases related to water and sanitation. But they also had some extraordinary indirect health benefits. They brought communities together. It gave us and them an understanding of what it means to live in and be part of a community within urban settings. And it helped to really support social cohesion. And this perhaps is my final point. There is a lot that we need to do in terms of health. We know the challenges. Mark described those enormously. Jim talked about the skill gaps. Tom also talked about, in some extraordinary circumstances, what is needed to provide all of that. But beyond a formal health service, beyond volunteers and informal caregivers, we need and can, through investment in community health action, actually generate a greater sense of social cohesion. Now, this morning, I quickly Googled social cohesion. I wanted a few stats on, what it does in terms of your physical health or your mental health. And there was a deluge of papers if you Google that term. From heart disease, to immunity, to insomnia, to pain from arthritis, to reducing smoking, to improving exercise, to decreasing people's blood pressure, decreasing violence, mental health, etc., etc. I could go on and on and on. We know that if you live in a community that is more cohesive, that you feel that you are a part of it, that you belong there, that you're part of some form of community action, and that you are supporting a network of carers, that is good for your health, for your physical health, your mental health, and on a population point of view, it has enormous benefits. We're currently facing an epidemic of loneliness around the world. 1 in 3 people say that they are lonely. And so all of the efforts that we do around health need to address that. And volunteering, supporting informal caregivers, supporting community health action can be a way of addressing that loneliness, but getting the biggest and most transformative thing for human capital, for health and for education, and that comes through social cohesion. So what do we need to do? Very quickly. We need to recognize and respect the value of volunteers, of informal caregivers, and of community health action. We need to invest in it, the skill gaps that Jim talked about. We need to invest in those skills. But we also need to invest in the connections between volunteers, between informal caregivers and formal systems, the connections that can be generated through community health actions. And above all, we need to protect these people. Volunteers and health workers are not targets. Red Cross, Red Crescent last year, over 70 volunteers were killed in the course of the duties that they were trying to do, and we know that there's many, many others that are. They are not targets, and they need to be protected, whether it's in a conflict zone or whether it's in an inner city hospital setting in a developed country. They need to be protected. Informal caregivers also need to be protected. They need to be protected from simply being considered to be cheap labour. And as the vast majority of informal caregivers are women, this comes back to some of the points that Jim were talking about in terms of gender issues. We need to protect and respect them. And in terms of community health action, we need to protect that from budget cuts. It's often the first thing to go, and yet we know that it's often the thing that can make broadly the biggest difference. So transforming human capital through health and education, we've talked about that, and we know it can be extremely transformative. But I will also argue that health and education systems can be transformed through the investment of different types of human and social capital. Thank you.
I'm going to ask the speakers to join me on stage here so that we can have an interactive session with all of you. Because I think if nothing else comes out of this morning's keynote, is an appreciation that we really need a whole of society and a multi-sectorial effort. If I ask the audience, how many of you can remember SARS? How many of you remember SARS? Okay, I think most people in this room. Well, SARS was actually 16 years ago, 1-6. SARS was 16 years ago, and the challenges that we face are going to be upon us within the next 10 years. So we don't have that much time left. And before I actually, can I ask, are there any questions from the floor? Yes, please. If we can just get you to just briefly identify yourself and who you'd like to address the question to. Thank you. We wanted this actually because in previous World Health Summits, one of the feedbacks that we had was that there was just not enough participation from the audience. Please.
Okay, hi, my name is Rowan Taha, and I'm with an organization called Multipod Mentoring. My question is for Dr. Julie. You stated that the unpaid workers or the informal workers are the equivalent of almost, if they were to be paid, they'd be paid almost 18 million sterling pounds, or the equivalent of another NHS. So is there any work being done perhaps to rally governments to pass a bill to get these informal healthcare workers, such as mothers and grandmothers and other people working at home and taking care of disabled children or perhaps the elderly, to get paid? Because if this is implemented in a developed country like the UK, perhaps it could be implemented in developing countries as well.
Julie?
No, thank you very much for your question. And I think that other panelists may well be able to contribute to this as well. I think all around the world, different governments are looking at these issues and looking at how to support informal caregivers in the most appropriate way. And pay may not be the answer completely. It may be much more around supporting in terms of providing respite, in terms of providing some training, in terms of ensuring that they're fully respected by the formal health services themselves. Many of the informal care givers wish to do that because it's a family member and it's something that they're doing from their heart. And they will gladly do that without pay. It doesn't need to be a monetary reward for it. They get plenty of reward from what they're doing. But they do need to be supported, they need to be protected, they need to be given time out when they require that. And what they often ask for is, I just want the respect. I want someone to understand what I'm doing. And when I need some extra help, I want to be able to call for it and get it quickly and not have to beg for it. But others, I think, on the panel may well have even greater experience than myself on this, and maybe I'll be able to contribute, particularly around some of the policy issues.
If I may, yes. It's interesting that you make the point. We've got evidence globally. Obviously, the UK figure is one, but globally, in terms of women's contribution to health and social care, over $3 trillion, of which 50% is unpaid. So it is a global phenomenon. On that matter, though, it's interesting to note that next year's G20 will be picking up this issue. So the group of 20 countries hosted by the Kingdom of Saudi Arabia next year will be looking at this and what are the policy issues and what are the role of the G20 to come towards it. So I think it's very much a debate of the political leadership and health and social care systems today.
We've got one more question here, and then, wow, great, this is wonderful. We think, please.
My name is Brigitte Bühlen. I made a foundation for family carers, informal carers. So my question is, all of you and all of us, perhaps we say we put care of them, but shouldn't we take care of us? We are the ones, each of us, who can come every day in the situation to be informal carer. We cannot say that these are the people outside here. No, we're inside. We are all in the same boat. We talk about us. And for me, it's a really big gap for us that we should bridge. We talk in our function, in our professionality, about those people. I think it would be very good and if we could talk about us, also in our professions. Then we could bridge a big gap.
Okay, thank you. What I'm going to do, I'm going to maybe group the questions together, and then we can, okay, so one issue is basically how do we look at not only care for others, but care for ourselves? Maybe, yeah, we'll go around, pass the microphone to a few of the other hands up so that we can get a flavor of the questions.
My name is Alpha Wuri. I am the Minister of Health from Sierra Leone. And in the initial statistics presented, it was shown how there is a weakness in the health workforce in the Mano River Union, Guinea, Liberia, and Sierra Leone. Most countries in West Africa try to get to the Abuja Declaration of 15% of the national budget spent on health. However, the bulk of the resources come from the international agencies, by that I mean the Global Funds, Gavi, or DFID in particular. The gap, however, seems to be that the funding is towards diseases rather than towards strengthening the health system, of which the human resource would be a major component. Now that there is a change in the architecture, in that the IMF are now looking at social protection and other things, will there be a conclusion, a drive from this World Health Summit towards HSS, the health systems, rather than towards the diseases? I thank you.
Thank you, Minister. Please, we'll take another question, please.
All right. Hi, my name is Mark Margolan. I'm a young medical student from the German Medical Students Association. And my question is to all of the panel, if you would imagine that you could change one thing in your country, you had unlimited power to change one thing, what would be the one thing be?
Okay.
Thank you.
Thank you. Okay, maybe we'll start off with those issues. So can I ask anyone? Jim, I mean, this issue of funding for health systems rather than diseases.
Yeah, and thank you, Minister, and congratulations for a lot of the work you're doing in your own country, which we're following with interest on some of these labor market challenges. Indeed, I think the evidence is overwhelming that if we want to build health systems or resilient systems or health systems functions, essential public health functions, we have to look at where's the majority of that investment needed, the infrastructure, the people, and the medicines and supplies. And increasingly, it's ironic that the same donors domestically will put 75 of their budget into the education and skills, but when it comes to their aid budgets, won't put the investment into people. They'll put the investment, as you rightly say, into the diseases and everything else. So how do we change that? And I think there's an opportunity. In terms of the specific question on the conclusion from the summit, I'll leave that to Julian and the organizers, but Minister, make your point known loudly.
Excellent point. Maybe Mark, can I ask you? You've listed 10 things. What would you tell our audience if you were given one?
Well, if I could respond to the question from the lady about us, the use of the word us, and I'm going to answer the question about my greatest dream and wish, if that's okay, John.
Sure.
I mean, you do realise that we're sitting in a country which is experimenting with paying for carers. So you can pay your loved ones, your brother, your sister, your mother, your father, and others to take care of people who are elderly and frail. There are roughly 4 levels of care. The basic level attracts a pay of €400 per month, roughly, and the highest level attracts pay of €1,800 per month. Now, I'm not saying again, to coin the Beatles, that money can buy you love, but it does recognise especially female labour. However, in Japan, they've consciously decided not to pay for voluntary home work because they think it ghettoises women. So there was a very active debate about what do you pay for and what's the overall strategy. My greatest wish, by the way, is to make sure that the health industry has the most motivated staff in the world, because actually we now face global competition from so many different industries for bright people that can do other things. And I think if we can manage to motivate our carers and our workforce, guess what? We're going to be just fine.
Tom, one wish.
Well, certainly for our situation in Sudan, it's to the end of conflict. You can't do anything, you can't progress when you have a state of chronic conflict and war. It really defeats everything. So I think if we have a real peace, a lasting peace in Sudan, now we'll have a chance to move ahead somewhat.
Okay.
You can't do much without it.
Right. Good point. Julie?
Yeah, single wish, what a challenge that is. I would say something around health empowering education curriculums. So actually looking at, this isn't curriculum for like medical students or for nursing students. This is your regular education curriculum. How can we make it more health empowering? How can we integrate from age 0 all the way through formal education systems, an understanding of health, how our bodies work, etc. But also the mental health issues. When we look at this epidemic of loneliness, but we also look at the mental health issues, particularly of younger people right now in many parts of the world, being empowered to be able to address that, talk about it, and overcome some of the stigma and discrimination, I think is extremely important. So I would say my wish lies outside of the formal health system and more into the education system.
Right. Jim?
I come from the UK, so at the moment I'd hope that Brexit would be dropped. But on a serious note, the impact of that is meant that we've got huge discrimination against, over 1/3 of the health workforce in the UK for not being of the same nationality. Foreign-born, foreign-trained health workers have made the NHS throughout its 70 years of history. And we're seeing complete disrespect in the diversity of the workforce. And that would be something in all countries, I think, to recognize, appreciate, and value the diversity of the workforce that exists and to invest in them if you want to invest in healthcare.
Right. No, thank you very much. And perhaps I can share, I would probably say that there's nothing like good governance, and there is nothing like addressing the dissonance that Mark shared with us, because the solutions are complex, and it really requires enormous political will and alignment. It's alignment between all the various parts of society that this is something that we collectively must address. You know, in a way, it's almost perhaps the health equivalent of climate change. We all feel climate change, but we don't feel the impact of what we've been describing. Perhaps Tom may face it most vividly, but when we are 18 million healthcare workers short in the next 10 years, no society will not feel it. And the question is, how do we get people to wake up from the stupor that they're in? So I think that these are issues that hopefully, having platforms such as the World Health Summit, platforms where we've got government, academia, civil society, industry, and the media here, we can collectively address this. Okay, there are a few other questions. Okay, so maybe we'll take three. Okay, we'll do one from here, and one from over there. So maybe we'll do from that side. Lady over there, please. If you want to stand up and get a microphone.
Good morning. Thank you for fantastic input speeches. My name is Tamsin Rose from Friends of Europe think tank in Brussels, and I'm really struck by the messages of the stories on the ground from Sudan, because that highlights the fact that some parts of the world have got a youth bulge and other parts of the world are aging rapidly. And in Brussels, I've hosted in my home over the last 18 months about 40 migrants largely from sub-Saharan Africa. And I asked them, why are you traveling to Europe? The chance of an education, the chance of a job. So there is this enormous human cognitive surplus out there that is being wasted because there is no investment in basic education and opportunities. And I see this as a big challenge for us to solve. And it's great to see that the health community is talking about the education system. And I'm wondering, the panel, how much overlap is there in the conversations happening here in health, where we see the skills gap and the support for basic education and literacy that would allow some of these loops to close, so people aren't leaving because they need an economic way to contribute and to grow.
Great, thank you. Okay, but there's one gentleman in the back who's been quite patient. You want to stand up and this?
Hi everyone, my name is Flora Cobello. I'm a young nurse from Finland, but originally from the Philippines. And I'm not sure whether everyone knows that the World Health Organization, in close collaboration with the International Council of Nurses, has declared 2020 as the year of nurses and midwives. But how do we ensure that this declaration doesn't just end in 2020 and becomes sustainable, and nurses have actually a seat at the decision and policy-making process? And the second question, and a commendation that I would like to make to the World Health Organization. They published 10 years ago this Code of Ethics for international recruitment of healthcare professionals. But in relation to that, high-income countries have started to recruit young nurses or nurses from low and middle-income countries to high-income countries, and which makes the healthcare system very fragile. So how do we ensure that it doesn't actually make the health system of low and middle-income countries fragile? Thank you.
Thank you. And we'll take one question from the gentleman in the back, yes.
Thank you very much. My name is Omar Hamid. I am from the Embassy of Sudan in Berlin, in charge of the health and higher education. I have a question to Dr. Tum Katina regarding the presentation he offered about Nuba Mountain in Sudan. Last year, in this room, Dr. Tedros, the Director General of the World Health Organization, broke into tears, offering moving remarks about a healthcare facility in Sudan. It was about humanitarian heart surgery clinic run in Khartoum, which covers the needy people not only in Sudan but around Africa. However, unfortunately, the exclusively Sudanese Nubia Mountain-based presentation offered included inaccurate information about health and education sectors in Sudan. And this information could be challenged from different points of view. First of all,
Sir, can we just have your question? Because
Yes.
there are quite a lot of people who want to
Yes.
ask questions. Mhm.
I will put my questions as this. The Nubia Mountain, it is not accurate that the Nubia Mountain lacks education and health. I have a very good examples. Our new Prime Minister, who was appointed 2 months ago, comes from the South Kordofan area, which is the same area of Nubia Mountains. Our current government is run by a sovereign council, which includes 2 members of the Nubia Mountains, one a university professor and one a military general. And the peace, he mentioned that the conflict is running 63 years ago. Now we have a peace negotiation going on in South Sudan. And so the point is, our new Minister of Health is an expert of the WHO who has established experience in the WHO. The question is, would your organization would be willing to come to the national government and join hands to address the needy people in the whole area instead of presenting information which focus only on a tiny area and totally neglect the rest of the country?
Okay.
Thank you very much.
Thank you very much. Thank you. Maybe we'll take one more question from here, please. Also, there was another hand up here. No. Okay, just one question.
Thank you. Thank you, Jim, and the colleagues for your presentation. I want you to
Can you just introduce yourself, please?
Oh, sorry. Benoit Kalasa, I work for UNAPA in New York. I want you to reflect on 2 issues. One is the skills gap. We are moving to a digital world. How do you see the world adapting to that, the workforce adapting to that? The second is the salary gap, which poses challenges on developing countries. Today, we have doctors from Sierra Leone, Ghana, Nigeria, making the diversity of the workforce in developed countries where they are not as needed as in developing countries. How do we make that inequality, how do we address that inequality?
Okay,
the doctors are needed in developing countries, but they move because of the salary gaps.
Okay, thank you very much. So in the last 5 minutes, maybe we can, Tom, if I can ask you to comment on the education, work, health nexus, and issues if you want to comment on Sudan. Mark, maybe if I can get you to comment on nursing and migration. And Jim and Julie, if you can comment on the latest about skills gaps and how can we address that. So, Tom?
I think for the issue about education, I think you're spot on. I think the main issue is how do you give skills to people to stay in the country. So provide the education in the country. I think the investment is well worth it to provide that so they stay there, so they don't have the impetus to emigrate. I think the future is in Africa. It's got a very positive growth rate. So I think really it's worth spending money now on those people that are there. You're right, the youth bulge is there in Africa. For my friend from Sudan, I'm sorry, معلش, لكن أنا قاعد في السودان بتاع 12 سنة. I'm in Nubia Mountains. I lived there for 12 years. So I know the situation. The region I'm talking about is the rebel-held territory of Nubia Mountains. We're still not at peace. We hope. There's been an issue last week where they came into Kauda. The first helicopter landed in Kauda for the first time in 8 years. There's not been any flight overhead for the past 8 years. So we hope that peace will come. We're not there yet. And we hope. So let's not get into political bickering about this issue. the facts I gave you are the facts. This is where I live for the past 12 years. Maybe there are Nuba in the government in Khartoum. They don't live in Nuba Mountains where I live. They've been in Khartoum, they've been maybe in El Obeid, maybe in Karugli. So, I mean, I live in the place.
Right. Thanks, Tom. Mark, nursing and migration?
Great question. We support Nursing Now with Lord Crisp and others, and we've been on the global tour as well. I would say three things as somebody who's led very large health organisations. Any health organisation that doesn't have a nurse on its top table isn't going to be a successful health organisation and won't be around that long. Two, we know that nurses comprise over 50% of the global workforce. They need that power, that respect, that leverage, and that degree of mobilisation. Thirdly, the industry now with the largest global motility in the world is healthcare. And if we are to try and change the south to north, the east to west flows, then we have to, A, get governments in those countries to invest more in healthcare. B, we have to get the recipient countries to forge, earn, learn, and return bilateral, trilateral, or multilateral agreements. And then thirdly, we have to actually embrace reverse innovation from parts of the world that can teach the so-called developed world how to address communicable and community disease in the 21st century. The age and the decade, the year and the decade of the nurse is upon us, and I genuinely believe without your mobilization and leadership, we're finished. Merry Christmas.
Thank you, Mark. And Julie and Jim, if you can address the issues of the skills gap.
Okay, well, thank you very much. I mean, you talked about the health and education nexus, and I think it really ought to be that it doesn't matter which door you enter, you end up with the skills that you need. So, for example, the example that I gave when I was talking about the community health training programs that we do, they're there to help volunteers, lay people gain health skills. But in doing so, they also gain literacy skills. And for adults who have missed out on education, this can be one way of improving reading and writing and numeracy skills. But it means that we need to design our programs in a way that perhaps start off very visual and then increasingly become more around reading, writing, numeracy, etc. And this can be done. So at the end of the day, you have some health skills, but you've also improved on adult literacy, which we know is incredibly important. And vice versa, as I said, biggest dream is to make sure that education systems are positive in terms of the messaging that they give around health, and that they're using plenty of health examples for teaching not just of science but maths or English, etc., so that you can have that real nexus between education and health. And I think that's absolutely vital in terms of some of the very basic skills that are needed. Digital, absolutely critical in terms of moving the health agenda further forward, also the education agenda, and helping to bridge some of the skill gaps. But ultimately, health is around caring, it's around face-to-face contact and making sure that still remains there, and that we're valuing, respecting, and supporting the care that takes place through all of the health services that we do, whether they be within the formal or the informal sector.
Jim?
Thanks. I mean, just recognizing what Tamsin, Flora, and Benoit all mentioned, you know, the whole issue of skills and jobs and opportunity come together here. Migration of health personnel in this challenge that we have is ever increasing. In the last decade, we've seen a 60% increase of people moving out of healthcare systems in the global south to the global north. Now, that in itself demonstrates that there are many different triggers that are happening there. There's a large economic pull, but there's also education, there's also opportunities for family, there's also
providing health and education opportunities for your children may be part of this thing. So we do need to take this issue very, very seriously indeed. And it comes back then about what are the skills and competencies that we need, and how do we put the investment into those to create jobs, to create career development, to create decent work. If we're not stimulating those type of opportunities, people will vote with their feet. Many people in this room have probably practiced outside of where they were first trained or first educated or first working. It is a global health phenomenon that we're all part of. So we have to connect with that. On the code of practice, there is currently a review of that instrument, and it's being chaired by Norway, co-chaired by Norway and then Indonesia. And there will be a report to the World Health Assembly next year on how to accommodate some of those challenges. And yes, a shout out for the Year of the Nurse and the Midwife next year. That was 2 years of diplomacy with member states to get them to celebrate this opportunity. And we're joined by colleagues here. The Deputy Executive Director from UNFPA is with us in the room, who's also a member of the steering committee with the nurses, the midwives, Nursing Now, and others. It's going to be an opportunity to celebrate, but it must be an opportunity to take action at country level to overcome some of the challenges we've all been discussing so that we have the ambition of health for all.
Well, thank you very much. And I think you'd agree with me that this has been a spectacular panel highlighting a really critical issue which the World Health Summit would like to bring to everyone's attention. So thank you for your attendance, and thank you for the great questions, and please thank the panel again.